Good afternoon. I'm Kevin Lyons. I'm the Executive Director of the Rheumatology Nurses Society, and we'd like to welcome you to the next edition of the Rheumatology Nurse Practice Google Hangout series covering challenging cases in rheumatology. Our faculty today is Vicki Sales, as well as Eileen Leiden, and they'll be sharing with you some challenging cases surrounding SLE and lupus. A couple of quick announcements. First off, a lot of the information that's covered is actually going to be focused within the next edition of the Rheumatology Nurse Practice publication. The current edition, if you haven't received this in your mailbox yet, you should receive it any day now. On this one, we're actually covering a continuation of spondyloarthropathies, but the next one is all about SLE and lupus. So make sure you go to the RNS website, which is rnsnurse.org and /RNP for Rheumatology Nurse Practice, and you can sign up. We also want to share with you, we have an exciting event coming up the first weekend of February, and it is the Pacific Coast Rheumatology Forum, or PCRF, because we all need another acronym, right? So PCRF, we're doing the first day is about immunology. We're doing the fundamentals of immunology. We're talking about the application of immunology to autoimmune disease. We're doing some group-based gaming. We're doing a cytokine challenge. We're doing some fire hose sessions around biologic therapies. Day 2 is all about SPA, spondyloarthropathies. We're covering psoriatic arthritis, reactive arthritis, IBD, uveitis, and we're covering ankylosing spondylitis. And it's going to be a great 2-day event, 9.5 credit hours. It is accredited by the RNS, and we invite you to come out with us to San Diego. Members between now and the end of the year can get in for $99. So it's a super value, and we also have a great faculty lineup. Check us out on Facebook and some of our other resources to find out more. So without further delay, this is going to be a quick 20 minutes of your life as we go through SLE, and I want to turn it over to our faculty. So let's take it away, Vicki and Eileen.
Hello. So today we have a lupus case. We have a 26-year-old Caucasian female who was diagnosed with lupus in January 2017. She had a positive ANA, an elevated anti-double-stranded DNA, low complements, malar rash, arthritis, glomerulonephritis, leukopenia, and serositis. She had a prior medical history of rosacea, a family history of heart disease. She smokes 1 pack of cigarettes a day. She's a social drinker, and she is planning a trip to Hawaii next month. Her current medications include hydroxychloroquine, 200 milligrams twice a day, oral contraceptive pill, 1 tablet once a day, calcium with vitamin D, 1 once a day, 1 multivitamin a day, prednisone 60 milligrams per day, furosemide 20 milligrams per day, and lisinopril 20 milligrams per day. So prior to her lupus diagnosis, she was in her usual state of health. And then in September 2016, she presented to her local dermatologist with a malar type rash that was raised and scaly. So this dermatologist initially treated her for rosacea, but the topicals did not help. Then she went to a second dermatologist. Second dermatologist also treated her for rosacea with doxycycline 40 milligrams once a day without improvement. So this dermatologist then went and did a biopsy of her nose, which showed interface dermatitis, which was consistent with eczema. But he wasn't satisfied with this and dug a little deeper and went for a second biopsy, now from the cheek. And now this was consistent with lupus with increased tissue mucin and lymphocytes and a thickened basement membrane. So then in January 2017, she presents to her primary care doctor with multiple joints that are painful, swollen, she has stiffness. She has oral ulcers, shortness of breath, with some chest tightness and a lot of swelling going from her legs up to her abdomen. She had weight gain, and then she's complaining of intermittent pleuritic chest pain. So from here, she was referred to a rheumatologist. So the rheumatologist does a workup, and the workup revealed an ANA of 1 to 16 40, a diffuse pattern, elevated anti-double-stranded, low complement. She has a low white count. She had anemia, and it turned out to be anemia of chronic disease, normal platelets, a normal creatinine, although her baseline creatinine was 0.7 and now it's 1.0. She also had a low albumin of 2.1. And her urine results showed 3+ proteinuria, 2 to 40 white blood cells with bacteria, 3 to 10 red blood cells, and a urine protein creatinine ratio of 6 grams. And also, on exam, actually on presentation, she had normal vital signs. She was normotensive at the time. So the rheumatologist started her on prednisone 60 milligrams once a day, hydroxychloroquine 200 milligrams twice a day, lisinopril 20 milligrams once a day, furosemide 20 milligrams once a day, and was referred to a nephrologist for a kidney biopsy as soon as possible. So now thinking about this case so far, some questions come to mind. So Vicki, just curious, why do you think it is sometimes difficult to diagnose a malar rash?
Well, a malar rash might be sometimes difficult because it can be confused with other skin conditions such as seborrhea, eczema, or rosacea. Also, in this case, sometimes a biopsy is not always correct, or a patient may have combined skin conditions.
Mm-hmm. Yeah, those are such good points, Vicki. Those other skin conditions are very similar. And I know I myself have come into problems with patients who have malar rash as well as rosacea. It is very hard to make the diagnosis. It's very hard to differentiate that. You know, the malar rash, which simulates the shape of a butterfly, and that's why it's called a butterfly rash. It often occurs in sun-exposed areas of the nose and the cheeks. It may also include the forehead and the chin. It crosses the nasal bridge, but it spares the nasolabial folds, and it can be flat or raised. Whereas rosacea presents with facial erythema that can be in variable amounts. It can affect also the nose, but often doesn't spare the nasolabial folds. Can also affect the cheeks, the forehead, and you can also see some superficial dilated blood vessels, as well as papules and pustules. Now, the seborrhea rash usually looks reddish pinkish, and it's scaling patches that can occur on the face, the nasolabial folds, the scalp, the hairline, the eyebrows, the ears. And finally, the eczema rash can appear dry and scaly. Initially, it's red and then can turn brownish, but itch is the primary symptom there. So, you know, and as we're seeing, like, although biopsies can be helpful to sort out the diagnosis, as you mentioned, they can be confusing. So, you know, the point here is if we have a hunch there's something more going on, it's important to ask for another biopsy, as in this case, or to refer the patient to another specialist to get to the bottom of it. So, Vicki, also, based on the clinical information of this case so far, what do you suspect the kidney biopsy will reveal?
Well, I think given the large degree of proteinuria and normal creatinine, my first thought is that the biopsy will reveal class 5 membranous nephropathy. But since there's some sediment in the urine and the DNA is high and complement's low, this could be a class 3 or 4. This is why I believe a kidney biopsy in this clinical setting will be extremely helpful.
Right, yeah. Now, I agree this is a mixed picture, but you know, all this high degree of proteinuria makes you want to jump at the class 5. So class 5, as you said, membranous, typically does have the bland sediment, like nothing in the urine, no white cells or red cells, but presents with usually greater than 3 grams of protein. You can have a normal to elevated creatinine, a normal blood pressure, absent to mild DNA, and usually normal complements, whereas class 4 diffuse proliferative, which is our most severe form of lupus nephritis, usually has red blood cells, white blood cells, and red blood cells CAS, and it usually has 1 to 3.5 grams of proteinuria. Serum creatinine that could be normal and go as high as dialysis dependent. An elevated blood pressure is often seen, as well as high DNA and low complement. So what was also interesting is this patient be on oral contraceptive pill. What would you recommend for her to be taking this? Would you make any suggestions, Vicki?
Definitely. I think she should stop taking the birth control pill because she's at increased risk of developing blood clots. Her high range of proteinuria, greater than 3.5 grams, makes her at increased risk of developing blood clots because of the loss of antithrombin 3, which is a natural blood thinner, as we know.
Mm-hmm. Right. Now, I completely agree. This nephrotic range proteinuria can cause her to be prothrombotic, and she must stop the oral contraceptive pill. So patients with lupus nephritis, particularly those with membranous nephropathy, have an increased risk of DVT, of renal vein thrombosis, as well as pulmonary embolism. Another interesting fact, because she's a smoker, that also increases her risk of blood clots. So she has more than enough reasons to stop the oral contraceptive. I completely agree.
Definitely.
Yeah. So what's also interesting is her presentation of these chest symptoms. What do you think is the most likely reason for this?
I would think first it would be serositis, which is an inflammation of the lining of the lungs, known as pleurisy, and or it could be her heart, known as pericarditis. She's describing pleuritic type pain when pain can worsen while taking a deep breath or coughing. She is also describing chest tightness, which could occur from fluid building up in her lungs or pericardium, making it more difficult for the heart to pump. This extra work causes chest pain. Sometimes serositis of the lungs and heart may or may not produce pleural or pericardial effusions.
Mm-hmm. Right. No, I agree. That's the most likely explanation. But what else could be happening that we don't want to miss?
I mean, it could be a PE, it could be a heart attack. As we just discussed, patients with nephrotic range proteinuria are prothrombotic, which could contribute to the development of a PE. Also, many patients with lupus have cardiolipin antibodies, which are associated with arterial and venous blood clots. Finally, lupus patients have increased incidence of heart attack due to the known association with atherosclerosis.
Mm-hmm. Right. No, those are great points. I'll also add, because she's got that nephrotic range proteinuria, she has an increased risk of hyperlipidemia. The fact that she's on steroids increases her risk of hypertension, diabetes, and also hyperlipidemia. Then she also has this family history of arteries and her smoking history. So those also increase her risk of myocardial infarction. Yes.
Exactly.
So given what we just talked about, would you add any other tests that the rheumatologist hasn't yet ordered?
I would add an antiphospholipid panel, maybe an ECG, electrocardiogram, VQ scan, chest x-ray, lower extremity Dopplers, and probably check her troponin levels.
Mm-hmm. Yes. Yes, I agree. So let's see what these results showed. So the chest x-ray did show some small bilateral pleural effusions, which goes with the pleurisy, no infiltrate or pneumothorax. But the echocardiogram did not show any pericardial effusion, but her ejection fraction was very good at 65%. And she doesn't seem to have any evidence of pulmonary embolism on the VQ scan, nor does she have any evidence of DVT. And her antiphospholipid panel is completely negative, which is reassuring. And then also her EKG showed it was normal. It didn't have any acute changes. And also the troponins, we checked 3 of them, that they were all normal, the normal range. So we're just going to continue it with the case here and to go over the kidney biopsy. So the kidney biopsy revealed the class 4 lupus nephritis, which, as we mentioned before, is the most severe form. So this patient needed to be admitted to the hospital, and the treatment that was required was 1 gram of salumedrol every day for 3 days, and then that was going to be followed by the 60 milligrams of prednisone daily. And she was also started on mycophenolate mofetil. So given these results, you know, we're really glad that this patient was pushed forward to have a kidney biopsy, because this affected how aggressive we had to treat this patient. Okay, so moving on with a few more questions, Vicki, for you. Earlier, we had mentioned starting her on lisinopril. And just curious, what are the benefits of this medication for lupus nephritis?
Well, ACE inhibitors such as lisinopril are recommended to reduce proteinuria, which she has, of course, and it can help prevent the progressive loss of her renal function. The recommended goal for protein excretion is less than 1,000 milligrams.
Mm-hmm.
So it will help with that.
Right, which is very good for us here and now. Now, given her current medication regimen that we just started her on, how would you counsel her regarding the use of birth control?
MMF is teratogenic, and she'll need some form of birth control, whether it be condoms or, you know, another form. But I would also ask her to discuss with her GYN an alternative longer-term contraception, such as a non-hormonal IUD. Something of that sort would be good, so that she didn't get pregnant. Right,
right. It's definitely a must-have conversation. Now, how about if she wanted to get pregnant? How would you counsel her?
I believe that pregnancy should be avoided during a renal flare such as hers, because it may worsen her renal disease and renal function. It's also recommended that pregnancy be avoided until the disease is well controlled, probably at least 6 months.
Okay. Yeah, sometimes easier said than done, but that's the advice we have to give them, right? The best outcomes. So she's lucky enough to be going to Hawaii soon. Is there anything you would tell her prior to her upcoming trip?
I think the most important thing for her to know is that she needs to use some sunblock, because sun exposure and causes photosensitivity in SLE. Many lupus rashes arise from sun-exposed areas which can cause flares of her systemic disease, which we don't want to happen. She should avoid exposure to direct or reflected sunlight and any source of UV light. Sunscreens that block both UVA and UVB have a SPF of over 55 are suggested.
Yeah, she's going to have to be super careful in the sun. So, but that's great advice. Thanks so much. So, you know, I just also wanted to give you some follow-up. So this patient, 6 weeks after treatment, she came back to see the rheumatologist, and she responded both clinically and serologically. Her urine protein creatinine ratio declined to 3.7 from 6.2, and her creatinine came back down to baseline of 0.7 from 1.0. Her complements and DNA both normalized, and her swelling improved. So the plan at this visit was now to start tapering the prednisone, to continue the MMF 1 gram twice a day. We're able to now DC the Lasix, and we were going to continue the hydroxychloroquine as well as the lisinopril. And we asked that she return in about 6 weeks when she comes back from her trip. And she seemed to be satisfied with these results. And that concludes our case.
Very interesting.
Yes.
That was awesome. Thank you so much, Eileen and Vicki. That was really great. A couple of follow-up points to this related to lupus is, of course, we have the next edition of the Rheumatology Nurse Practice coming out that's focused on lupus, and that will be out probably within the next few weeks. Again, sign up on the RNS website at rnsnurse.org/RMP. We also have our next broadcast of the Google Hangout series on the challenging cases coming up in early 2018. We have a lot of exciting activities coming up in 2018 for sure. Two more points I really want to share with you is if you're a current member of the RNS, the videos from the 2017 annual conference are available on the rnsnurse.org website. And one in particular I want to point out is our own Monica Ritchie shared a lupus update, antiphospholipid syndrome update, and it was phenomenal. She had a patient on stage. She did a live case study with that patient. So that video is now available on the website as another follow-up to SLE. And also I want to share with you PJ Day. It's an event that we do with the Lupus Foundation of America and coming up in May. And that event, you can find out more information on Facebook and our website to where to raise money for lupus awareness and research. You can wear your pajamas to work, because who wouldn't love to do that, right? But if you can't wear your pajamas, if you work in an academic institution, we also have some unique t-shirts and some other things that we can share with you. So stay tuned for hearing about PJ Day coming up to focus on lupus awareness. Well, Vicki and Eileen, we appreciate this very quick but very intensive case study that you shared with us. Are there any closing comments that you'd like to make?
Go ahead, Vicki.
No, I'm just glad this patient did so well with the treatment. Not everybody does that well.
Yeah. And just that, the idea that sometimes things are not always as they look, and with the facial rash that required a second biopsy, and then maybe the first thought that the kidney, the biopsy, the lupus nephritis wasn't going to be as severe as it was. So getting more information from our testing, it really, sometimes you have to push things a little further to get the right diagnosis and get our patient treated appropriately.
Awesome. Well, thank you both for your time today, and also thank you for what you do for the patients and for rheumatology as a specialty. But we'd like to conclude our broadcast. Thank you for watching. This and all other Google Hangout broadcasts are available on the rnsnurse.org website for replay. You're welcome to share them with your colleagues, with everyone out there, and we just want to thank you and look forward to seeing you in the new year with the next broadcast. Happy New Year, everyone. Good day.